Hello, and welcome to the Cat's Health Podcast, the show where we hope to connect our community with healthcare information that's relatable, understandable, and useful to your life, and where you get to know better the neighbors providing your care here. I'm your host, Carter Anderson, and in today's episode, we'll be talking about obesity with family medicine physician assistant Mary Robinson. Before we get started, two quick disclaimers. First, the comments in this podcast do not necessarily reflect the views of Cat's Health. Second, the information in this podcast is not intended to be construed as personal medical advice. Always consult your primary care provider with your questions and concerns regarding your health. Hey Mary, thanks so much for taking some time to chat with us today. We had Mary back in season 1, episode 10 of our podcast series here. She was on an episode with Dr. Wepler, so we kind of covered some get to know you questions there with her. So if you want to learn more about Mary, you can go back and give that episode a listen in season 1. So we will go ahead and get started with our very first question here. What is obesity exactly? That's kind of like a really hard definition, I'm sure, but...
Correct, because there's so much that goes into it, and there's so many misnomers and thoughts about it that are completely different than what we thought 20, 30 years ago. So obesity is actually considered a chronic relapsing problem. So it is just like high blood pressure, diabetes, any of that type of stuff. So it is not something that people choose to have. It is something that they have, just like you would have high blood pressure, have diabetes. And it's treatable, and it is caused by several different things. And so just like having high blood pressure and diabetes, it's something that we can treat. Where a long time before, 20, 30 years ago, we thought that obesity was you just need to change your diet and exercise. So much more than that has been found over the last 20, 30, 40 years as far as obesity goes. So, it's where the body promotes adipose tissue or fat cells to cause dysfunction and cause abnormal deposits of adiposity or fat tissue, but it's also adverse effects to your metabolic rate, biochemical, and your psychosocial health.
So it impacts all facets of your health, not just one single facet.
Correct.
A multifaceted issue for sure.
Yes.
You shared some pretty, I would say, startling data with us for projections over the next 5 years by 2030. There's some pretty interesting statistics in there. I wasn't sure if there were some that jump out to you more than others, or what ones you really want to share with people to kind of let them know what's kind of at stake here, honestly.
So the scary thing is in the next 5 years, we are seeing that obesity is going to become a significant health problem. They're saying that nearly 1 in 2 adults will have a BMI of greater than 30 by 2030. They're noticing, too, that in that group that nearly 1 in 4 will have severe obesity, which would be a BMI of greater than 35. So, yes, it's a huge concern and problem, and because it impacts all parts of your life. And if you have any other health problems, it's something we need to talk about and treat.
Right. It's an issue that will impact all of your health and impact other facets of it too, not just it's kind of such a widespread issue. So we'll kind of get into the next multifaceted question here. What causes obesity?
So that's another fun thing because it is caused by several things. So there are things that you have no impact on. So that'd be things outside of your body. So that would be environmental. Other things would be genetics plays a huge role that we are just barely on the tip of the ice finding out. There are different types of obesity that are actually genetically linked, and they're finding more of those genes every single day and working on trying to make medications that would actually treat specifically for those gene expressions. Other things you can't choose. So like your parents, if they are overweight or have excess fat pre-having kids, that can affect you as you get older. If you're exposed to different types of pollutants, if there's so many things.
Like you said, it really is a disease. There's so many external factors that can impact it and make it occur that it's not just you.
No, and it's, neurobehavioral. So there's a lot in your brain. There's different hormones in your gut that regulate being hungry and full. All of that plays into this. And we could get down into the super nitty-gritty, but that's a lot of hard things for people to understand. But just know there are so many things that cause obesity that there's not just one thing that we can do to fix this.
Right. So it's kind of like figuring out which issue is the most root cause of it for specific people and then kind of go about remedying it that way.
Yes.
There are some people out there that talk about the sensation of never feeling full or satisfied when they eat. Is there like a term or an explanation for that at all?
Absolutely. So what we talk about when I see people for this, what we talk about is we call it food noise. So it's your brain telling you that you are always hungry, even though your body's not necessarily hungry. And it's an extremely very real thing. And it's something that, people don't like to talk about, but yes, it is a real thing.
Just occurs where it's just that sensation of the brain.
Yep.
So has there been any advancements in like treating
So
situations like
some
that?
of the medications we have do actually help with that. So that's a nice thing. So, yep.
Can you explain the health risks associated with obesity kind of overall? That's another, again, a multifaceted question there. So.
Huge multifaceted question. So there are tons of comorbidities and complications that come with having excess weight. So we see people tend to have higher rates of anxiety, depression. Eating disorders can be an issue. Heart problems, so that would be high blood pressure, irregular heart rates, stroke. There are 13 different cancers that are actually genetically 100% linked to obesity. So, and those can include breast cancer, colon cancer, ovarian cancer, to name a few. I mean, we've had problems. Sleep apnea is a complication of obesity, diabetes, increased risk of having gallstones, problems with periods for women. You can have gout, arthritis, joint disease. I mean, the list goes on and on. Things that we treat on a routine basis with people. All of that can be linked to obesity.
Wow. The part about the cancers and stuff like that are increased with obesity as well. That's kind of a couple of the big ones right there too that are really increased with the prevalence of obesity. So there's so many different facets and ways it impacts.
I would say acid reflux is another big one that I didn't think about.
What are the treatment options available for individuals struggling with obesity, including medical and surgical treatments?
So we have several different options, and the big thing with treating obesity is it is 100% focused on the person. So it is all about what they want to do, beliefs, everything. So we have medications we can do. Obviously, we have surgeries. I mean, we do offer sleeve gastrectomy here with Dr. Rizek, but we're also looking at behavior modifications with lifestyle changes and with diet. The Obesity Medicine Association, who I am one of their members and working towards my certificate in obesity medicine, they have 4 pillars that we consider how we treat obesity. One is based on nutrition, so it's a meal plan, so based on what people like. So I know there's always tons of talk about different diets. Do I do keto? Do I do intermittent fasting? Do I do an all carnivore diet? Do I do all plant-based? And a lot of that as far as nutrition goes is I always tell everybody, I'm going to meet you where you're at, because everybody has a different like and different needs. And so within those needs, I mean, financial also comes into all that too. So we will work with that as far as nutrition goes and trying to make better choices to help with eating healthier and better to help reduce your excess weight or with obesity. Physical activity is also a huge part of this, and making sure that we are staying active. And a lot of people, when you think about physical activity, is a lot of people think they need to go out and do 30 minutes of something that's super hardcore, so like running or intense walking. The big thing is that with activity, we want to start where you're at. So if you have problems with being able to walk, if you have problems, we have people who have joint pain, especially when you have excess weight. We can start with like chair yoga. We can do chair exercises. We're talking about small, specific things. I always tell people I see in counsel for this that it does not have to be 30 minutes all once a day. If we do small little increments throughout the day, 10 minutes at a time, that's all I'm asking for. Any movement is better than no movement at all.
Those small little incremental changes can help,
Yep.
like you said, lead up to, I've done 30 minutes over the whole day, and then pretty soon get to...
And I always tell them, I'm like, if you're gardening, doing house cleaning, going up and down the stairs, all of that counts towards your activity level. The goal is to slowly increase it over time so that you are doing more and more. That is beyond what you would normally do in a day's time.
There you go. And then before you know it, you'll be up and doing more than you
Yep.
ever thought you could. So awesome.
Yep. And then another big part of it too is the behavior part of it. So we have lots of stigma and biases and thoughts about how we should be with obesity. Mm-hmm. And I mean, they're from external sources. I mean, if you look at like even at marketing stuff, if you specifically like targeted at obesity stuff, most of those pictures tend to show no faces and mainly just the mid area of showing a bigger stomach.
Right.
So there's lots of things to overcome, but people also have biases of themselves too, and working through that as well. So, I mean, there's a lot of things even psychologically we have to work through and talk about too.
The psychological aspect of it and stuff like that. So what are the things you kind of have to work through with people at certain times? Is there certain points of it? Is it just kind of just case by case basis? Honestly,
it's case by case, yeah. I mean, there's some people, people have a history of eating disorders. I mean, that's a different route we have to go. Some people, they've been told that, if you would just eat right and exercise, you'll lose weight, which is not necessarily true either. So there's different things that everybody deals with that we kind of dive into. Working on what we call SMART goals, making a specific goal that is achievable to work towards our goal. So, but yeah. And of course, then the big thing that I get the most questions about, because I do the medical side of it, is medications. What medications can I take? And so there's lots with that too. So.
I was going to say, is that something that's kind of really taken off in the past few years, or like have there always been medications like that kind of around?
There's always been medications to help treat obesity, but yes, within the last 5 years, that has definitely taken off. I mean, with all of the publicity around the GLPs is where a lot of the medication part is coming into play the last several years.
So lots of different ways to treat it and
Yes.
different options and stuff like that. So how significant is the role of diet and exercise in the treatment of obesity, and what recommendations you typically make? We kind of touched on the importance of exercise earlier.
Yes.
But
So exercise and diet are huge. I mean, we can't treat obesity without them. Just like I know there's a lot of people who, we're all looking for the quick fix, but there is no such thing. So with obesity, this is something that we will treat lifelong. So, and I know I get that question a lot of times too. If I start medications, will I be on this lifelong? Most likely, yes. But diet and exercise are huge. So with diet, I like to focus on protein intake because protein is what's going to keep you fuller longer. And so as I tell patients, I go, how I recommend you eat is how I teach people with diabetes to eat. So it's very, very similar. So a lot of it is making sure, as far as like your fluid intake, focusing more on water, trying to reduce regular pop, juices, coffee. Because a lot of coffee, when you start talking to people how they take their coffee, a lot of people do sugar and creamer, which have a lot of sugar in it. So trying to change that aspect of it. When we sit down to a meal, I recommend everybody try to drink a glass of water first because that will help make you feel fuller faster. And then when you're eating your meal, I always recommend starting with your protein first. And so we're aiming for 60 grams of protein in a day, which is actually extremely hard if you think about it.
I was going to say, that's quite a lot.
It is. And with we have, if you go to Walmart, there's a whole section now with protein chips, protein bars, protein shakes, protein cereal, protein waffles. There's tons of things now that help with that. And you can buy protein powders and add them to the things that you make at home to help increase getting that amount of protein in your diet. So starting with your protein, I would say stick with your lean proteins. So it's going to be your chicken, your turkey, your porks. We live in Iowa. Red meat is a huge thing. And I always tell everybody, I'm not going to tell you can't eat anything. There's no one thing you cannot eat. It's all about moderation. So if you want to have a steak, have a steak. Sticking to that 4 ounce, the size of your palm, helps with that. And then so when you're sitting down to the meal, so eat your proteins first, because I want you to eat the foods that you need to sustain your body for nutrition, but also those foods that we recommend to help with weight loss, we want you to eat those first. So protein is always the first thing I recommend you eat. The next thing I recommend is your vegetables. So we're looking at your vegetables that are not starchy. So that does not include potatoes, corn, or peas. And of course, we're in sweet corn season, so that's hard too. But otherwise, all your other vegetables, I always tell everybody, I have a list of vegetables I give out. Your lettuces, kohlrabi, celery, carrots, cauliflower, peppers. There's a whole list. I call them the free foods. Eat them until you are blue in the face.
That's what I was just going to ask about with all those increasing your protein intake and stuff like that. The balance out to that is increasing your fiber intake as well, because otherwise you can have negative effects with that. So with those vegetables and stuff like that, those non-starchy ones help with increase the fiber intake and stuff like that.
Yep, and they recommend that your non-starchy vegetables be at least half of your plate.
Okay.
So, and then a quarter would be your protein, and then the last quarter would be your carbohydrates. That would be your potato, that would be your rice, that would be beans, that would be milk rolls. Because at that point, as you're going through your meal, you should be starting to feel fuller, so the hope is that you would eat less of that.
At the end,
at the end.
Last.
Yep.
Okay.
Yep. And we talk about different types of protein. Like I said, we have all those protein replacements we have, but cottage cheese is a great form of protein. Eggs, 3 eggs is 21 grams of protein, so that's always a great breakfast. Milk, yes, it has protein in it, but we got to watch because it's got the carbs too. But a 8-ounce glass of milk will have 12 grams of protein in it. Greek yogurt is a great source. I have different recipes that I recommend too that you can make with Greek yogurt to have, bread is a huge thing. So I have a recipe for, we call it 3-ingredient bagel or roll, and it's Greek yogurt, self-rising flour, and you mix those together, and then you egg wash, and then you can put any type of seasoning on top and bake them. And yes, it's got a little bit of that yogurt tang, but it's really, really good. And it's a good replacement.
Do you know how much protein those would have in it off the top of your head?
So that would depend on the yogurt you would use. So,
right. Gotcha.
But yeah.
Cool. Let's talk about obesity and mental health. What do you see and hear from patients, and what do you want people to know?
So this is the hardest part, I would say, as far as treating obesity, because, like I said, people have been with stigma and bias. There's a huge disconnect because over the years, and we're getting better at it, but a lot of people feel alienated because they have excess weight. And so that is a huge part that we have to overcome. And yeah, it's a huge thing. And we still see it. Like, one of the big things I know that people that have excess weight, they don't like to travel because, like, airplanes, not made for people who have excess weight.
Right.
Going to the doctor's office, sometimes chairs are not big enough. Scales are where people can see it, like in the hallway. And so talking about that stuff in front of other people makes people apprehensive to go to visits because of that kind of stuff. Not having the tools that you should have for people who have excess weight. There are so many different things.
You live in a world that's not set up for you. And
correct.
Of course, that would make you uncomfortable because you have this chronic condition and you're not able to go about your day as you would like because of the condition that you're facing.
Yep, because you feel like you can't be part of that because people look at you differently.
Right. With the stigma around scales and weights and stuff, how do you combat that here at Cass Health?
Okay, so I know with obesity, stigma is a huge thing. And so for a lot of people who deal with excessive weight, one of the first things you do when you come into an office, what's one of the first things we do is vital signs. And what's one of those vital signs is getting your weight. And for people who deal with obesity, it's not fun. And so one way to combat that, we're better at it because we have a little bit more privacy here now with it, is moving those scales into a more private area so people can't hear what is saying. Like I said, we've done better. We have some privacy. Some things we could do even more for privacy is to put those little screens that the only way you can see the numbers is you have to look directly on and you can't see it from side to side would be an option. But yeah, that's one of the huge things is nobody likes to be weighed in front of anybody else. That's a very sensitive, very personal thing.
Right. So there's kind of like the barriers or screens around the scales itself, and like the scale doesn't say anything here, right? Like when it reads the number and then the nurse tries to keep it quiet as well, I would assume.
Yes.
So,
yep.
Absolutely. So what would you want people to know about how they should attack that, how they should go about dealing with those feelings and thoughts and things like that?
So we kind of work through with that. If people have significant issues with that, I always recommend seeing someone specifically for therapy to kind of work through those issues, but also trying to find, your tribe that can help back you up. And that's where your primary provider comes in as a huge person to go to be able to talk about this stuff too, so that you have somebody in your corner to help kind of vote and motivate you.
Absolutely. So when people see you for like obesity management and stuff like that, will they be like referred to you from their primary care, or like how does that work?
So that really depends on providers. Some providers are very comfortable doing some of this and prescribing the medicine. Some are not. And I am more than happy to see people for this. And I do see them specifically for this, whereas their primary will do everything else. And I always tell everybody, you're not alone. I'm in the same boat with you guys because I have also just struggled with having excess weight most of my life too. And I understand the bias and stigma. I've felt it myself. So I always tell them, I said, you're not alone.
Right.
I said, we will get through this. The world is changing. As science emerges, we have more and more things at our hands to be able to treat this and to help people feel like they belong and are heard.
More tools in the toolbox and more people in your tribe, like you said.
Yep.
More people to your primary care, and then Mary's there to help you too. So what strategies do you suggest for maintaining weight loss and preventing relapse after treatment?
So, I always like to tell everybody, losing the weight is the easy part. Maintaining is going to be the hardest because It is going to be a lifelong struggle. This is something that's not going to go away after you've been on medicine for, a year. Mm-hmm. It's something that you will struggle with for the rest of your life. So it goes back to those 4 pillars, working on making sure we're still following our nutrition, making sure that we're staying physically active, that we're still working on all of those things as far as behaviors, and making sure that we're still meeting those goals and making goals to stay in what we call the maintenance phase. Mm-hmm. Some people, yes, people do have surgery to have with weight loss, but data has shown that 5 to 7 years after that surgery, people will start gaining weight back again. Mm-hmm. And at that point, that's where the strategies of, once again, nutrition, behavior modification, exercise, and using medications will help.
Like you said, there's no quick fix, and those pillars help. If you fall back on those, you will be supported strongly. Absolutely. What advancements or trends do you see on the horizon for obesity treatment and management?
So, the GLPs have opened up quite a bit, and that's a huge talk. And yes, they are super expensive. Yes, a lot of insurances don't cover them. But I do know after the last conference I'm at, there's at least 5 new medicines coming out the pipeline for specifically to treat obesity. 2 of them may be as soon as next year.
Wow.
So, right now, they kind of have a little corner, a little niche in the pharmaceutical world. Mm-hmm. But as more companies are looking at these medicines, the prices should come down. The big thing will be is for CMS and our higher ups to recognize that obesity is a chronic health condition. It is not a choice. The AMA has already recognized that, and they are, along with the Obesity Medicine Association, they're trying to push for that to pass through our federal government to say, yes, obesity is a chronic health condition and needs to be treated just like we treat diabetes and high blood pressure.
So when people come to see you or be treated for obesity management and stuff like that, would that distinction change how those things are paid for?
I hope so. That is my dream, is that at some point that distinction will be made, and yes, they will be paying for the things we need to treat our patients.
Absolutely. I remember a little bit ago, was that a couple weeks ago, we were talking about there's like a pill form of the weight loss medication?
Yes.
Was that one of the new ones that'll be on the market coming up? Or?
Yep. So Novo Nordisk, they have Wegovy, or semaglutide, which is their injectable GLP for weight loss. They came out and said that they are working on a pill form, which I'm not surprised at all, because Wegovy is the weight loss part of their medications, which is semaglutide. For diabetes, that is Ozempic, which is also semaglutide. And so right now, for diabetes, they have a medicine called Rybelsus, which is also semaglutide, but it's in an oral tablet form. So since they already have that in the market, going to a pill form for weight loss is not a shock. Not a shock and not a giant reach.
Gotcha.
And the nice thing is if they can continue to work on making these medications, pills are much easier and cheaper to make than it is to make the injectables that we have right now.
So it brings the cost and accessibility out to more people. Absolutely.
Yeah.
Awesome.
Yep. And access right now, as of right now, there is no shortage of any of the medicines we do have on the market anymore. The federal government came out and said that they have enough now. The big is it's the price sticker right now.
Right. Absolutely. A couple different things on the horizon that sound promising, so that's cool.
Yes.
For patients that are ready to take the first step towards weight loss or making changes, what should they do?
So actually, we have quite a few options. So number one, talk to your primary provider. They can, if they're not comfortable and don't know what to do, they know who to send you to. The other great way, especially here at Cass Health, is we have a bariatric coordinator, Julie. If you call the hospital and talk to her, she can kind of walk you through which, if you're not sure which direction you want to go. If you're thinking you want to look into surgical interventions, we can get you in to see Dr. Rizek and kind of go that route. If you are more wanting to look at medication management and you don't have a primary in our area, then she sends you towards my way. So we've got several avenues that we can do to help with that. We have our dietitian who has gotten really good with a lot of this because she does a lot of our education now, especially with the surgical patients, and her and I are trying to work more on stuff for the medical side of it as well.
Gotcha. A whole team here at Cass Health to kind of help you figure out that chronic condition. So thank you so much, Mary, for taking some time to chat with us today.
Absolutely.
It was fun to kind of start this podcast series about obesity. So
yeah.
Thank you.
Thank you.